Hey guys, happy Sunday. So I just wanted to check in and throw a little makeup on. I probably don't need makeup because it's Sunday and I plan on doing some homework, doing a little reset. I've got quite a few dishes, but I thought why not? It gives me an excuse to sit down in front of my phone for a little bit, which if I didn't do this, it's a little bit harder to take you around. So let's see, I have been at my addiction medicine rotation for 1 week now, and because we missed Tuesday and she works like 7 to 8 hour shifts depending on the day and the patient load, we're like 30 hours in, 30 out of 50 hours. I just need 50 hours for this rotation, and unfortunately I can't do more, which I have mixed feelings about anyhow, but this isn't considered inpatient. It's really not crisis stabilization. It is specifically the addiction portion of this program that I need. So just the 50 hours and then we're good to go, which means I've got like a half a week to complete and I'll be finished up at this site. All right, first thing I want to address and mention is that there are 2 PMHNPs at this partial hospitalization program / IOP, intensive outpatient substance use program site. The one I am with right now, she's my current preceptor, and the other one, she's a slightly newer PMHNP, but she has been a PMHNP for just about 2 years at this point, and she has another job that is inpatient detox. And I think that counts towards an inpatient clinical rotation. So I was putting my time in at the PHP IOP location, and she walked in to chit chat with us in between patients because it's not a steady stream, because it's not appointment based, it's walk-in based. And hopefully it means I made a good impression on her, but she was like, "Do you still need hours?" Or like, "Do you need more hours for this semester?" And I said, "Yeah, I do. It's been a struggle." And she said, "Well, I work at this inpatient detox center. I could like text my supervisor and see if I can bring you on as a student." And I was like, "That would be fantastic." She was like, "Is there any time frame or minimum amount of experience that's going to be a problem? Because I've only been a PMHNP for like a year and a half, 2 years." I said, "I think as long as it's over a year, we're good to go." So she texted her supervisor and they said, "Yes, no problem." And she gave me the supervisor's information, her email. I sent it all to my director and placement coordinator, and they are now working to get me into this other location, which is actually a lot closer than the one. So I live in like the Canton South area, and I'm currently driving to Akron Fair Lawn, which is, it's got potential to be about a 40-minute drive depending on traffic, and traffic usually sucks the further north you go. And and the location of this place she's at is, I guess, within the Maslin area, which is like 15 to 20 minutes from me. So I'm excited about that. The problem is she works like PRN there, and we didn't discuss it in depth. It was kind of just like a, "Hey, yeah, we could do this. That'd be fun. I work Tuesdays. Would that work for you? What's your schedule like?" But I'm like 100% sure she mentioned that she works 4 hours on Tuesday and only Tuesdays, which is 4 hours a week, which even if we get this ball rolling right now and there's like approximately 10 weeks left in this semester, and that's a big if because it takes forever to get balls rolling, that gives me 40 extra hours. I'll take the 40 hours 100%. It's a start. I'm learning that that's what the semester is going to have to be, is a bit of an amalgamation of hours, but it's like a pro-con. Extra hours, met another resource, another person in the field, which is nice. I'd hate to become like the psychiatrist I had emailed, who has been a psychiatrist for 30 years and claims that she doesn't know anybody in the field. That will not be me. I think she's full of shit. But it won't be me. So I'm hoping that there are other PMHNPs at this next location also, because there's only 2 at my current location. So I'm with the one, I am going to be with the other, as long as everything checks out. So then I hope I go to the second location with the one preceptor and find another preceptor and either do more hours there or by some stroke of luck, just find another location. So that was pretty cool. That made me feel good because she didn't have to take me on as a student. She didn't have to even ask. I didn't reach out to her. I should have. I probably should. I feel like I've been very proactive because I have reached out to 10 to 15 providers at this point, and I have been turned down by all of them for one reason or another. 5 of them were from my job location, and they didn't give me a good reason. They don't have to, but they were official no's. A couple of them that I reached out to would be yeses, but yeses if I want to schedule into 2027, 2028, and I cannot do that. So it's not necessarily a no, sorry, we don't take students. It's a, you should have reached out when you started your program. And I had no idea. And the program I'm in, again, prides themselves on finding clinical sites for their students. That was like a big drawing factor. I liked it because it had the DNP program, which not all schools offer. I just want to get it all done. I like it because it is a brick and mortar in Northeast Ohio, and it felt to me like that meant that I would get a good education. There's something about diploma mills that I was trying to avoid. I don't know what the education is like at some of these online programs, but I thought, this is hopefully this is the last time I'm going to do this. Go back to school, get my terminal degree. This is a school that's got a lot of history. And then they say that they find students placement. So I'm like, that's perfect. That's perfect. This sounds like a good school. It's probably more expensive than a diploma mill, but considering it has everything I want, the degree, the assistance, the brick and mortar, but it still has a lot of online classes, which means flexibility for me. Sounds perfect. So that's why I picked it. Now here I am doing my part, reaching out to 10 to 15 people and getting turned down and not getting much help from the school. So I'm not going to lie, I kind of got to a point where I'm like, well, I did just about what I can do. I reached out to a lot of people. I utilized the resources I have, the people I know, the nurses that I've worked with in the past. And the program says that they will place their students. So I have gone above and beyond in my search to help get this rolling. So I didn't even reach out to this PMHNP at my current location. She brought it up to me, and that was so nice, and I hope that I can be that provider one day for other students who are struggling. So that is the first update about this current clinical rotation. The second update is I've learned a lot of useful, just like working knowledge, not necessarily about the meds. Honestly, I'm not a super huge fan of how like the patient interactions go, and it's just because I'm not used to it. Like I said, there's no appointments. They walk in, and then the PMHNP that I'm with is pretty familiar with these patients. There is a certain census, and there's only 2 PMHNPs, so you kind of know when someone comes in and when they graduate the program. So she's familiar. So when they say, hey, I need a refill on this med, it's like, okay, I'll refill your med. There are general questions. How are you feeling? Any suicidal thoughts? Any side effects that you've noticed? But it doesn't help me understand how we got to those meds. Did they come with those meds? Did we decide on those meds? Did we have to switch many meds? We don't seem to be switching many meds, which is good if the patients feel stable. Some of them are dual diagnosis. Some are primarily substance use disorder, probably a history of trauma. There's not a ton of digging into the patients, and I don't have any of the patient information. I barely get an age. Like I try and look over at her computer while she's going through to put medication prescriptions in because I don't have access to it, and we can't plan on seeing patients because we don't know when they're coming. So it's basically just a person sits down and says, hey, I want this refilled. And it's like, okay, how you feeling? Okay, bye. Which it's great to know that there can be a point that you get to that, like that aspect of your career. She knows them. That's what her day-to-day looks like. It seems like it's working well for her. But as a student, I'm not learning much from that area specifically. However, she is full of pearls about how to make her day-to-day easier, how to study certain things, how to get comfortable with medications. And I'll give you some examples, and I think I might even screen record them and pull them up to show you. So she showed me an app called Text Expander. I had never heard of it before, but it's like dot phrases, or depending on what charting system you use, there are pre-made phrases that you can pull up and document that way. And it's like that, but you make your own, which is good and bad. On one hand, you have to be disciplined to make appropriate dot phrases. On the other hand, you're going to have to type it out anyhow if you want to create appropriate notes for your patients. So you may as well do it once in this app and then have it for the future. It does seem like it's a paid app. I am currently in a free trial period right now, but it seems useful. It seems like something I'll probably keep, which is, it's good because it's going to be super helpful, but it's bad because I could say that about so many apps. So many useful things that are all subscription based. But this seems like a good one. And you can put, like I said, anything in it. And there are some things that like auto-populate, so you can add in the date and time. And when you enter the code for that to pop up, it pops up with the current date and the current time. So if I entered that code and then I waited 2 minutes and I entered that code again, it would be 2 minutes later, it would show you. So that I found super helpful in itself, because as I chart on these patients, because I don't have access to the charting system, I'm using a Word document. I don't have a lot of patient information. So because it is my own computer and because you don't need that for the program, because it does become a liability if you have protected health information that I would have on my computer, and then I'm sending it to my school program, and then that's just a whole thing. So it's just very basic information, but I'm able to just enter this code and document when a patient stops in. I don't have to like really think too much about it, like, oh, I should enter like 02/11/26. What time is it? Oh, it's like 3:30. I just one code and it's in. And then my preceptor, she asks a certain set of questions for part of her intake, her complete psych eval, which is a hair different from my last preceptors. It's similar in screening for different diagnoses, but she approaches it differently. And if I'm going to be assessing some of these patients for her, I want to make sure I do it to her standards. So during one of her intakes, I wrote down word for word her questions and I ended up entering that into a dot phrase, and I can just put in a code and that will pop up in my Word document, and then I can go through and enter that in. So that is the first life-changing thing that she introduced me to. That seems like it will be helpful through school, into my career, especially early on. Because I'm pretty sure she learned that from a doctor she worked under, a psychiatrist she worked under, who created these phrases himself. I think you can share them. I don't know exactly how it works, if the creator has to share them or what, because she didn't exactly volunteer to share them with me, but that's okay because I need hands-on experience with creating them so I can internalize what I'm using. But it sounds like the provider she was working with went in and entered every DSM criteria for diagnosis and created a dot phrase for it. So you just enter a code and every criteria for major depressive disorder pops up, and you can go through it with the patient. Have you felt this, that, this, how long? Which is so helpful because it's all right there. All right, so this is the Text Expander app. Let's go ahead and create something. So you create a label so you know what you are searching for, and then you give it an abbreviation, something that makes sense for what you're using. So we're going to do my signature, something that I might put in at the end of an email or something. So you literally just create an abbreviation, create a label, put what you want in the text box. and then it just automatically saves. So I'm going to come over here and then put in my abbreviation, and it auto-populates. And then you can do that with as much information in it as you want. So this is one that I already had created. It's :sky, based on a location that I'm at, and it is the information that was sent to me by the PMHNP that I'm with. And it's like her intake information. So here's some examples of things that I've been trying to mess with. None of these are perfect yet. I want to go through when I have time and figure out what's going to work for me and what I'm going to use more often on a daily basis. The next thing she was super helpful about is explaining ICD-10 codes. So we don't really learn about ICD-10 codes in school, but we have to use them to chart on our patients. So I'll show you that in my Typhon documentation when I pull it up. But you have to basically give the patient a diagnosis and then chart on what you did for that patient from the program point of view. A little different from the actual provider and working point of view, but from the program's point of view, give some basic information and then give them a diagnosis via ICD-10 code and essentially support it in your documentation. And she has given me so many tips about how to utilize the ICD-10 codes to support your prescribing. So you get less insurance companies asking for prior authorizations because you've already, I don't know if that's exactly how it works, but something along those lines. You're essentially supporting your documentation and supporting the ICD-10 code and putting the whole picture together, which isn't something that I necessarily thought about specifically and isn't something that was necessarily taught to us, but it makes sense that if you're going to prescribe certain medication, if you're going to prescribe, I don't know, hydroxyzine for a major depressive disorder, that doesn't exactly line up. Why are we giving that? So you have to have your list of diagnoses. You have to have symptoms that the patient's presenting with. You have to document your MSE and all of these things. So the hydroxyzine then makes sense how you're prescribing it, which brings me to another point. She told me that she used to work for a psychiatrist who, prior to agreeing to work with her and prior to having her prescribe for patients, this is what she said. It sounds super unrealistic to the extent in which she said it. To a certain extent, maybe. But she said that he had her write down every single off-label use for medications that she might have to prescribe. So I don't know if that's the caveat, which made it shorter, but that's still a hefty list. Every single off-label use for medications and what they do and how they work and what you might use them as off-label for, before he would let her prescribe for his patients. Which, on one hand, what a learning experience. She told me she went through Stahl's prescriber's guide and went through like every medication and wrote down what is the actual indication or like FDA approval and what is the off-label use or indication. And she's very familiar with medications, familiar and comfortable with them. So my last preceptor, I would say, was far less comfortable with medications. She had the big ones down, the psych ones, the SSRIs, antipsychotics, stimulants for ADHD, pretty familiar with those, but certain things would throw her off, even like propranolol for anxiety, because it is associated, it's a beta blocker, and beta blockers technically are indicated for heart rate, blood pressure. And because there is that difference in indication versus what it's being prescribed for, she was very uncomfortable prescribing those. She would get a baseline, set of vitals, but a lot of times she would feel more comfortable if the patient had seen a cardiologist. And frankly, propranolol varies so widely in dosing that it's not necessary to see a cardiologist if you're overall healthy. If you have a heart condition, yeah, sure, maybe, but you'll also have other cardiac medications and you'll want to check interactions and stability and that type of thing. But this provider is super comfortable, even just refilling blood pressure medications if the patients are out, because they are stuck in this partial hospitalization program. They don't necessarily have access to outside doctors unless there's an emergency and they have to go to the hospital. They take care of all of their medical and psych in-house. And if they can't see one of the medical nurse practitioners for one reason or another. My girl is just like, yeah, sure. What do you need? Have you been feeling? Have you had something? Just check with the patient. How do they look? And I think a big part of that is spending so much time studying how the medications work and putting in the work. And she was an ICU nurse before going back to school and working in psych. She did some ICU nursing. She did some inpatient psych nursing, it sounds like, and then went back to school. And she's worked in a couple different places since she's been a PMHNP. So she does have that medical knowledge that some people, there are some strong believers that psych is a calling, and you want to go into psych. So like in nursing school, that is your goal. No need to go into medicine or medical specialties or step downs or anything like that, because you're going to be a psych nurse. What does it matter? Well, it matters because humans are body systems. Everybody's got body systems. Everyone has a heart and lungs, and things happen. So it's so important to be comfortable with all of the body systems and the medications. So I do think that there are some people that want to like kick you out of the club. Like, oh, you don't belong in the psych club because you were an ICU nurse. Clearly you had other intentions. No. My trajectory has been all over the place, and I've grown from that. Okay, I wiped the lip stain off and straightened these bangs because, well, I look a little crazy when my bangs aren't down. So finally, another thing that I've gone through with my preceptor is talking about board prep, because there's a lot of downtime when patients aren't coming through on an appointment basis, and they just like straggle their way in between group. So in that downtime, I'm like, well, how did you prep for boards? It sounds like she graduated in 2022 as a PMHNP. So a couple years of experience. Boards weren't that far behind her at this point. And she said that she used the Purple Book, which I have heard of. And I did just recently buy it, although I have not gone through it yet. And then she used another book that's like yellowish. I have it saved in my Amazon cart, but I can't think of what it is offhand, so maybe I'll put it here. And then she did self-study, because at that point it sounds like she was either pregnant or had one child and was pregnant again, or she was in the throes of motherhood and didn't have money to just throw at study programs, because there are a lot that you could utilize. So she did a lot of self-study, but I'm not gonna lie, I do like videos. I like hearing. So that's something that I'm kind of disappointed in this whole PMHNP program about, is when they put out videos, educational videos, they are just the most broad things ever. Like, hey, in major depressive disorder, you'll likely prescribe SSRIs. SSRIs work on serotonin. It's in the name. Next. It's like, tell me about your experiences. Tell me about that one time you tried Effexor over Zoloft, and this is what happened. And I'm not getting that from the program, but a lot of study guides do tend to have that. So when I took my CCRN, I did some self-study, I did question bank books, and I also did the Nicole Kupchik video series. And it was fantastic. It was fantastic because she had a story for everything. She had a story about this one time I took care of a hemodynamically unstable patient and had to use a swan. And this is how I memorized the numbers. And this is what it looked like. And this is what happens when you accidentally don't deflate that balloon. And I heard a story one time, a nurse did this. And then it sticks with you. So at my state job, there are a handful of PMHNPs that do not work as providers. They work as managers, supervisors, but they went through the schooling and they got the degree, passed boards, all of that. And I was talking to one of them. I said, what did you use to study? And she told me about this program, I guess, called Georgette's PMHNP study guide, Georgette's PMHNP study review or board review or something like that. And it sounds like it is live classes, not like live and in person, but like live Zoom, like not pre-recorded. So on one hand, that sounds amazing. I have a feeling that as she goes, she gets feedback from students and tell me about this, tell me about that. There's room for questions as part of the Zoom session. So I'm sure that she has created this study guide or presentation that has a lot of good information in it. And it sounds like questions are based on previous board questions, like come from a certain bank that perhaps have been used in the past, something along those lines. I don't know exactly how it's done, but from what it sounds like, they're pretty accurate questions. So it sounds like a really useful tool, but on the other hand, because it's live Zoom meetings, you have to put aside like 3 to 5 hours, essentially Monday through Friday, to make these meetings. And then if you do the like intensive review course, I think that's 6.5 hours on a Sunday. So it's doable and I think I will do it because that's how I learn, and because I'm not getting all of that from this program. I'd like to hear her point of view and her stories while I self-study as well. I'll just have to find time to put aside, because I just took this last week, and then going into the first half of the coming week, off from both of my jobs in order to get this addiction medicine rotation in, because I'm doing essentially Monday through Friday for a week and a half to just get these 50 hours out. So it's like, well, I can't just turn around and then take off another entire week where I cannot work, because I will be like essentially in class for so many hours from, I think it's 11 a.m. Eastern Standard Time, because she's maybe based out of Arizona. Either way, I think I might have to put it off a month or so I can get some hours in at work. But even then, I still have 150 hours to catch up on for my inpatient rotation, or like crisis stabilization. So at some point, that's going to pop up and bite me, and I'm going to also have to put work off at that point too, which I did put some money away for this specifically, but it really pains me to use it, because I know there's also going to be a period of time where I will be studying for boards, taking boards, getting a new job, getting credentialed, getting my DEA number. There's going to be this period of time, like from boards on, where I guess I'll have time to work as a nurse. Like, they can't take that degree away from you, so I'll have time to work then. But I just want to make sure I have money for the DEA number, because you have to pay for that. It's not cheap. You have to pay for the test. You have to pay for boards. There are going to be expenses that are coming up, and I don't want to deplete this small bit of savings I have, even though I did put it away for the period of time that I would be in clinicals. But I'm really weighing that back and forth, especially because my medical job is still offering pretty hefty bonuses right now, because they're pretty short-staffed. And if I could just find a little drive, find a little motivation to go without sleep, or as much sleep as I think I need, and just put some of those hours in, I could help myself immensely. But the struggle's real. This is full-time school. And in addition to completing tests and discussion posts, I'm doing the preceptor hours, and then I am trying to get hours in at my state job, and then at my hospital job, and then study on my own time, and then spend time with family. And it is hard to find the discipline when I don't have to, because I have some money put away, and eventually I'll be a provider and can pay myself back. But I know that the smart thing to do is to do everything I can to stay afloat while I can. So we'll see. All right, I think the smart thing for me to do now is dishes, because I have the house to myself currently, and dishes are easier to do that way for some reason. So I'm gonna go do some dishes, catch those up. I've got to scan in my hours before I forget to do that. For some reason, if I have to physically do something, like my papers, my hours are downstairs, so I have to grab that paper and bring it upstairs and put it in my scanner and scan it to my computer and then send it into my school. It's so many steps that it doesn't take that long. It doesn't take long at all. But the fact that it's so many steps makes it a thing in my brain where I'm like, oh, gotta do that at some point today, even though it's really no big deal. But I need to get it done. Otherwise, it's gonna weigh on me. So maybe I'll even do that before I do my dishes, just to get it out of my brain. So I gotta submit my hours for the week, do my dishes. I have to enter patient encounters still, which will hopefully go quick because they're all very similar. They're all substance use disorder, med refills, and typical safety information and medication education. Not a ton that I need to think about. It's just going through and entering like 10 patients a day for 4 days last week because we didn't do Tuesday. So like 40 patients. but they're basic, but they're time consuming, especially depending on how the internet decides to work, because you can enter ICD-10 codes if you memorize them, and I just don't, and I haven't even considered it. So I do the drop down mental health, drop down substance use, drop down alcohol use disorder, drop down abuse versus dependence, drop down remission versus, so it's just time consuming. All right, let's go ahead and add a patient encounter together. So we're going to add a new case log, and we're going to go ahead and add it for Monday, which is when my rotation started. And then you'll see I have some information blocked out coming up. That's my class, my preceptor, my site that I'm at, and then we've got patient demographics. I kind of speed right through this. I sped it up a little bit. We've got the clinical information, how much time you spent with the patient, how much time you consulted with your preceptor, the patient's chief complaint, and then we're going to look at social problems we address, which with this population, a lot of times it's substance abuse, it's safety, it's housing, maybe income. And then this drop down is for procedures and skills, which you'll see a ton of procedures and skills that we do not do as PMHNPs, but they do include medication education, and they include mental health screening scales. What else do we have here? Screen for mental health disorders, suicide safety screen. And then we go back up to the top to enter our ICD code. I had to block out a couple things here. So this is the drop down I'm talking about. Drop down to mental health. We're going to drop down to substance use disorders. We are going to drop down, let's call it alcohol related use and abuse. And he is in remission. Great. So then, is he taking any drugs right now? We'll say yes. Maybe he takes ibuprofen as needed. Is he taking any prescription drugs? We'll say yes. He's had 2 prescription drugs, and we are going to refill 2 prescription drugs. So we'll say he's on Zoloft and Buspar. So we'll say we're refilling an antidepressant and an anxiolytic. And then the clinical setting was an office setting. Follow-up within the week. They need weekly refills and no referrals. Everything's done in-house. And now we write a little clinical note of how the encounter went. Very basic for school. Like I said, they just kind of want to know that you've seen patients and what that looked like. If this was an actual SOAP note or something that would go to insurance, it would have to include a lot more detail. But we're basically going to say patient arrives to the medical psych office as part of the PHP program. He is requesting for his medication to be refilled. He's on Zoloft and Wellbutrin. I cannot type. And now you can see it. So he said he denied current side effects on these medications. He denies suicidal ideation, homicidal ideation, and audio or visual hallucinations. Patient spoke briefly about how things are going with his new roommate. In their housing complex, and overall he describes his mood as good. Patient educated on returning to medical psych office if further needs arise. Prescription sent to in-house pharmacy, and then we submit it. But it's okay, I'll sit down, I'll knock it out, maybe I'll memorize it so I can just enter them quickly. And then I'd like to study, but how do I want to, you know what I need to do? I think maybe I'll enter some DSM criteria into the text expander, so I'm processing it and have it available to me. So maybe I'll do that. And also, I don't know if I mentioned it, probably not. I've been playing games periodically as a little treat for myself for getting work done. I've been playing that, I think they call it All in Whole. And if you do, like if you watch YouTube videos and you have you're obviously watching a YouTube video. Advertisements, sometimes you'll see the games advertised, and it's the one where you just like move this hole around and things drop into it and it grows, and then you have to get, it's mindless. It's mindless, and it's been soothing. So I've been wasting time on that, unfortunately. I should probably just delete it right now while I'm ahead, but we'll see. All right, let's see what I can get into. All right, so I guess we got some things caught up this Sunday. Thanks for spending time with me, and I hope you were able to take away something valuable, and I'll see you next time. Bye.